Thank you. My second scenario is a male, 45 years old. He presented in blastic phase of CML in November 2022. So-called and ELTS score were high. He had no comorbidities. The diagnosis was explained to him that would need to be he would need to take therapy for acute leukemia, enter back the chronic phase before he could qualify to take the TKIs. Because I think in Nigeria, the teaching there is we treat the acute leukemia, then push them into the chronic phase, and then they start the TKI. We don't usually like giving the TKIs side by side with the um, acute leukemia treatments. Although in a few cases we have given high dose imatinib for AML, but um, we prefer to give them induction therapy for the acute leukemia. So he's learned. He read about all the side effects of the chemotherapy, the DA 3+8 that he would need, 3+7 that he would need to take, and he became scared. So he declined to take the chemotherapy and left, went back to where he was, which was in the eastern part of the country. Um, there, he was convinced in the local hospital where he was given some therapy. The name of the chemotherapy he was given was not known because he wasn't given a referral letter to come back. But he came back to us, and when we did a repeat blood film, we found out that he had reverted back to chronic phase. So then a sample was sent for BCR-ABL testing, which showed E14A2 transcript type at 1.392. Now, our worry when he came back was compliance because in the first instance he had declined to take induction therapy, but despite that he was still commenced on imatinib 400 milligrams per day and counseled, and luckily he has been compliant with that, but he has failed to achieve complete hematological remission, and that has been for the last 11 months. He still has leukocytosis and thrombocytopenia with the latest white blood cell count 16,700, latest platelet count 73,000. I've encouraged him to repeat another BCR ABL, but he has promised to do another one in January. In this kind of scenario, I mean, where finances are a problem and the patient is not responding adequately to the imatinib, what would your approach be in this case?
Naeem, would you care to lead?
Okay, interesting case. Yeah, interesting case. So I think one thing needs to, and I'm sure with your experience, Dr. Lendre, that this patient eventually would go for, preferably should go for a transplant if there is resources are there or the center is there. That he will eventually will go. The objective now is how to get him into some sort of remission into a chronic phase two. He already got chemotherapy in February 2023. That means he's coming close to almost a year now. And I can tell you that some of these, he's on imatinib right now, but he may not be in chronic phase. His hematological parameters may indicate hematological as a chronic phase, but most likely this is the disease related that he still has low platelet count. Even if you don't find too many of blasts in the bone marrow, a persistent thrombocytopenia itself is a high risk, which we used to call accelerated phase, or he is probably brewing the disease there, which just is going is a matter of time is going to come back. So how to approach this case is if he is willing to, and you have the resources available for stem cell transplant, then I would treat him to be a bit more aggressive, either with another TKI stronger to something like dasatinib or ponatinib with some sort of chemotherapy is because almost been a year and then take him to transplant. The tolerability, sometimes you have to take pros and cons because he may drop his platelet counts more, that's possible, but he will also get over his disease, most likely, if we give him a better tyrosine kinase inhibitor plus minus chemotherapy is willing to take this. But eventually, the objective is to switch to him to a different TKI because there looks like he was already in AML. He has an intrinsic resistance also, although we don't have any results of the mutation. But he could be RUNX1 positive, he could be ASXL positive. So I think this is what we need to do to be a bit more aggressive and then take him to transplant. That's my take on this one because he's 45 years old, and I think he should get a bit more aggressive therapy now.
Beppe, would you like to comment?
Okay, so I totally agree with what Naeem said, but I would like, which was the last BCR Abelson, because this is an increase of white blood cell count, as you said, there is not achieving a complete hematologic remission, and there is also thromboplatelets and so on. But the last BCR Abelson that you were mentioning in your slide has been performed or not yet?
No, not yet. He's planning to do one in January.
I think that this is essential because after the, I would say, the chemotherapy that he received in another place, he was able to achieve 1 point of BCR Abelson. So 1.3, if I remember well. So I think that this is important to know exactly if this increase in white blood cell count is due to I would say, so I would repeat at this moment both BCR Abelson and also bone marrow, just to see if additional cytogenetic if this is possible before taking a decision on this case, because probably there has been also a little bit of change in the nature. Why with the he responded very well to the chemotherapy, achieving also the pH positive clone was down to 1%. So this can be a good option, just also in case of, we say, if the BCR Abelson is increased, of course, I will follow. But if it is not so much increase, it's not responsible for the loss of hematological response because maybe there are other infections or other problems. Probably I would a little bit change my mind, and I would try just to see if there is a response to chemotherapy alone before, of course, even in this case, to proceed to or to consider the cell transplant.
Lanre, what do you think?
Well, I mean, the option now is to repeat another BCRA bill and then to probably to repeat another marrow, send for cytogenetics, and if possible, change him to another TKI. But I won't find out if he would need a tyrosine kinase domain mutation analysis before changing him to another, before being aggressive with the treatment by changing to another TKI.
Yes, I would
Sorry, can
consider
you
doing a
repeat the last
mutation.
phrase? Can you repeat
She's
it?
asking whether should we do a mutation. I think if the patient you feel that is failing is not responding well and has thrombocytopenia persist, I think a mutation analysis is useful, especially if we
Yes.
have a sensitive TKI. Pepe, your comment, please.
No. Yes, I think that this is the correct thing. However, what we know that it was not a patient so compliant to the therapy, but in origin it was already a very advanced case, so it was needing chemotherapy. Did he receive it in another place? Is achieved a good initial good response with a single cycle and the variables determination. So I think that this could be a way of to say, okay, he's responding to chemotherapy, we can perform a second cycle, and then to see after recovering if we can maintain him with the TKI therapy after to move directly to stem cell transplant. This is possibility. Stem cell transplant is an option for this guy or not?
He's 45 years old. I think. Dr. Lendre, what do you think?
Hello?
Yes, I mean, I would probably be more inclined for a stem cell transplant, to take him to transplant, because I'm afraid of his compliance. And then even if he switched over to a second TKI, the side effects of the second TKI may make him not compliant. So I'm more towards a stem cell transplant for him if he can afford it.
There are some interesting
Yes,
questions coming through on the chat. We might just have a look in case we lose them. So Siddiq Hussein from South Africa says, what are the chances of achieving molecular response if patient is in blastic CML post-allo stem cell transplant, if patient did not achieve any prior molecular response? Would you care to comment on the question?
May
Yes,
I? Or go ahead, Beppe.
please, Naeem, go on.
Yeah, so I think, yes, there is a good chance with the stem cell, if it's a myeloablative conditioning, especially for a 45 years old, the patient should go into a molecular response, especially if the patient is in chronic phase. But the question was the blastic phase. If the patient goes through a transplant through a blastic phase, the chances of molecular response, remission is there. Yes, it is there. And one has to be vigilant about reducing the time period of the immune suppression and taper it off earlier than the chronic phase patients. And the second thing is there is general recommendation or consensus that post stem cell transplant, once the patient who have gone through a transplant in a blastic phase, once they recover their counts around day 50 or 60, they do get started back on their on the TKI that they originally responded to. If there, especially if there's no mutation that is resistant, and also the one that got them into some sort of response, you can restart post-transplant maintenance therapy with a TKI if you take them to transplant in a blastic phase, the one who had a blastic phase. So there is still a very good chance that they can go into molecular remission post-stem cell transplant with the chemotherapy.
Beppe?
Absolutely. One additional point. In this case, after stem cell transplant, would you continue TKI therapy? Hello, can you hear me?
Yeah. So I think, what do you think, Dr. Landry? The blastic phase, there is a general recommendation to use it if they go through, if the patient has original disease was the blastic phase. The CIBMTR study that that they say there was no difference of use of maintenance therapy post-transplant was in the chronic phase. So if the patient goes into a transplant in a chronic phase, then probably the maintenance therapy does not work and you can follow the molecular response. If you find them become positive, you can always restart them on some sort of TKI therapy. For a blastic phase, the one who already had a blastic phase, it's an overall general trend is to put them on maintenance therapy once they recover.
Okay, I agree.
Thank you. And Lanre, unless you have any final comment here, if you do, yes, and if not, we'll move on.
No, I don't have any comments. Thank you.
Okay, thank you. Thank you very much.